Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at IHEA. Welcome, and thank you for registering for today's webinar, The Economic Effects of Mental Health Interventions in Low and Middle Income Countries. Today's webinar will run for approximately 90 minutes and will be recorded and uploaded on the IHEA website after. Before we begin the webinar today, I just wanted to run through a couple housekeeping items. If you experience any technical issues during today's call, please write them in the chat box at the bottom of your screen. I will be happy to assist. Everyone on the line has been muted except for our speakers today in an effort to eliminate background noise. If you have any questions during the webinar, please utilize the chat box. I will now pass things over to Julia. Julia, over to you.
Thank you very much, Chanel. Good afternoon, good morning, depending on wherever you are. My name is Julia Greco. I'm one of the conveners of the Special Interest Group on Mental Health Economics at the IHEA. And I am very excited to introduce Kate Olkin today. She will present her paper co-authored by a big team about the economic effects of mental health interventions in low and middle income countries. As a bit of background about Kate, Kate is on the faculty of the Blavatnik School of Government at the University of Oxford. Her work is in labor, public, behavioral and development economics. So as well as this project, other work on mental health includes a study on the education and labor market effects of an app to treat depression in teens in South Africa, led by Prof. Alan Stein. Kate has other projects on effects of information interventions on labor market and health behavior and the role of expectations and aspirations in investment decisions. She's an affiliate at the Abdul Latif Jameel Poverty Action Lab and the Center for the Study of the African Economies. So welcome, Kate, and welcome Mark Witt as well, is the co-author. And so Kate will be speaking for around 45 minutes. If you have any clarifications throughout, feel free to drop them in the chat. And at the end, we can have a Q&A session. Thank you very much. Over to you, Kate.
Great. Thank you very much to Julia and to the whole team for having me. Just before starting, I wanted first to give a shout out to Mark Witte, one of the co-author team who's managed to join us, and then also to some fantastic research assistants. So John Walker and Alice Carhill are both on the line. And then we've also had a number of other people working very hard at the University of Cape Town on sorting the data for what's been a monumental effort. So thank you to all of them for their work. And just to say, if there's any pressing questions, I'm very happy to take them during. So you can sort of put them in the chat in the first instance. I can see the chat, but also feel free to interrupt me if there's anything urgent that you think we need to get to before the discussion. But Mark can also answer all of the hard technical questions in the chat. So I don't think for this audience, I need to do a lot of motivation for this paper, but we know that mental health disorders are one of both the most widely prevalent and the most costly non-communicable diseases in the world. So currently between 11 and 18% of people worldwide have either a mental health or a substance use disorder at any one time. There's a lot of different cost estimates flying around depending on how you do the methodology, but one prominent estimate suggests that the costs of both the medical care and income losses of these diseases were estimated at about $2.5 trillion in 2010. So, whatever you think of the cost estimates, those were similar to estimates that were given for both cancer or chronic respiratory disease. So the burden of disease from mental health disorders is huge. In high-income countries, there's been a lot of evidence that treating these disorders both has mental health and quality of life impacts and has economic impacts. It reduces sick leave, absenteeism, and improves the likelihood that people return to work. And in high-income countries, these economic benefits have been one of the major benefits that have been used by advocates to start to broaden access to treatment for mental health disorders. So it's been a really important part, for example, of the expansion of the NHS, moving from just doing antidepressant drugs into talk therapy, was a paper that was written showing that these economic benefits actually meant that the mental health treatment would pay for itself. However, until recently, it's been quite difficult to study the question of how mental health treatment affects these sort of more economic outcomes in low and middle income countries. This is for a range of reasons. So, some of the evidence in high income countries has actually come from administrative data and evidence on treatment rollouts. Those haven't happened yet in many low and middle income countries, so it's difficult to study national policies. And until very recently, there wasn't an evidence base of mental health interventions in low and middle income countries. So a review by Crick Lund, the lead author of the paper back in 2010, only found 9 studies that were going to be able to answer this question. So until recently, there hasn't been a lot of evidence on this. So what we're going to do here is ask the question of how receiving treatment for a mental health disorder, if you are diagnosed with one, affects people's economic outcomes in low and middle income countries. So we ran a systematic search for studies in low and middle income countries that screen for a mental health condition, test an intervention that addresses mental health disorders, and measure any of a list of economic outcomes. And the search ended in August 2018. We screened 12,243 papers and did a full reading of 964 of them. So you can see that narrowing down, we were trying to cast the net quite wide to make sure that we picked up a wide range of economic outcomes. And we end up with 115 RCT program estimates from 30 papers. And so then we're going to move to run a meta-analysis looking at disaggregating the effects of these mental health treatments by outcome, also by the type of intervention and the type of disorder that's treated. We then ask some questions about the robustness of our estimates, so correcting both for publication bias and the characteristics of the studies. And then I'll talk a bit about these today, but these are a little bit more of the work in progress part of the paper. We first look at mechanisms, so asking whether we can say anything about how these mental health interventions have effects on particularly work-related outcomes, a subset of the economic outcomes that we focus on. And then we also did some work collecting cost data, which I'm not going to talk about today. So you can see here the just numbers coming out of the search that we did. And you can see the sort of motivation that I was talking about. There's been a huge increase in the number of studies that are done fitting our search criteria very recently. And that's been largely because of, in the sort of global mental health community, a real push towards trying to improve access to these treatments in low and middle income countries, and a lot of funder interest, therefore, in studying the treatments that have worked in high income countries or treatments used in specifically for low and middle income countries, and evaluating the effects. So what do we find in a nutshell? So we disaggregated outcomes into work-related outcomes and other economic outcomes. I'll talk a bit more about this in the search strategy, but the work-related outcomes were by far the most commonly measured in the interventions that we saw. So they were measured in 87% of interventions. If we average across them, so aggregating all of them together, we find that they have positive and a mental health treatment has a positive and significant effect on this group of work-related outcomes of about 0.16 standard deviations. We're also interested in looking at outcomes which are very similarly measured, and we have enough of these in the work-related outcomes family to do that. We don't find an effect on employment, so on whether people have gone back to work or they are working, but we do find quite a lot of movement at the intensive margin. So a 0.19 standard deviation decrease in measures of being unable to work. So that's one commonly used measure of a disability, not necessarily particularly linked to any one condition, but just a broad measure of whether people report being able to work. And a 0.34 standard deviation improvement on qualitative scales of how people rate their own disability in relation to work, so how they're able to perform their work or how they're functioning at work. We draw much less strong conclusions about other economic outcomes, because there's quite a wide range of other economic outcomes, and there's quite a lot of heterogeneity between the outcomes that are measured. When we disaggregate by disorder, we actually find similar effects across a range of different mental health disorders. We also find similar effects for different single interventions, so both drug and therapy as interventions. But if you interventions that have combinations of both have larger effects on work-related outcomes and economic outcomes as a whole. This is in line with the clinical literature, which tends to find that these combination interventions have larger effects on mental health. So we're finding a positive and significant effect of mental health treatments on work-related outcomes, the main ones that we're able to measure, that's pretty homogeneous across different types of disorders and different types of treatment for them. And then moving on to the robustness, we find these are largely robust to controls for study characteristics and testing for publication bias. And we're able to say some quite interesting things about the mechanisms behind these changes in economic outcomes. So first of all, we find that we have broader clinical evidence that these interventions have effects on a range of different health outcomes. So they both improve mental health symptoms, but they also reduce disability and they improve social functioning. So we coded all of those outcomes, and we can say that that's true in the general clinical study evidence base, but it's also true in the interventions in our sample. So it's the interventions that are improving economic outcomes are also improving these clinical outcomes. So that's one piece of evidence suggesting that that's how the interventions are working. We also see that interventions that have larger positive effects on these health outcomes have larger effects on work-related outcomes. So that gives you some suggestive evidence that, in fact, the treatment is affecting the work-related outcomes through effects on these mechanisms. And then finally, we take some individual level data, and we're able to show that this mechanism of so the reductions in mental health disorders that are affected by the treatment are correlated with reductions in days unable to work. So that again suggests that the pathway through which the treatment affects these economic outcomes is actually going through changes in health outcomes. These interventions are also pretty cost effective. So they have a mean of about $279 per participant, median of $96. So these are in the range of, particularly compared to other economic interventions, are fairly cost effective. In terms of contribution, the main contribution is to literature in both economics and in health that's looked at this question on the economic effects of mental health interventions. So there's been quite a bit of work in developed countries, both meta-analytic and studies of national reforms to increase access to mental health treatment, that's shown that these treatments reduce absence, improve work functioning, and improve earnings, although there's less clear evidence on whether they help people return to work at the extensive margin. So there's that evidence base in developed countries, but there've only been very few studies done in developing countries, and some on economic outcomes, and some of these have been with quite particular populations. And so our contribution is sort of threefold. The first is in comparison to the studies that look in one particular country, we're doing a systematic review. So that's going to be across a range of different contexts, disorders, and types of intervention. We also review both the economic and the health literature, which often isn't done in systematic reviews in the health literature. And we look across different languages. So we translated some studies from Chinese, for example, that wouldn't otherwise have been included. And then, it's the first review of this kind, to our knowledge, to be done in low and middle income countries. We don't know whether, that you could think of a range of reasons why effects might be bigger or smaller in a very different economic environment and context. But it seemed, and in a context where treatments may be run in way less well-resourced health systems. So it seemed very important to see whether the findings from developed countries translated in this context. Which also relates to economic literature on meta-analysis. And then there's also broad economic literature on the effects of poor physical health on economic productivity. But there's been much less, so many of us will have been familiar with work that's been done on, for example, the arguments for the cost effectiveness of treating malaria or iron deficiency, but mental health interventions have been relatively under prioritized by many global development funders. And so this evidence is important in that context. So today I'm going to go through a little bit of background on some of the conditions that we looked at, the search and sample, the empirical strategy we use, the results. I'll just give you some highlights of the robustness and then talk a little bit about mechanisms. I'll just pause there in case there are any questions before I get into the meat of the talk. Yeah, so please just unmute and ask at any stage if there's anything that would be useful to ask. So this is obviously a diverse disciplinary audience. So I think just two sort of facts that are useful background. We look across a range of different mental health disorders. So of the ones that are on this graph, we're going to be covering so common mental disorders. Those are things like depression and anxiety, which are much more prevalent. So this is looking at prevalence estimates in lower middle income countries and the proportion of the population who have these disorders. But we also include, as is common in the health literature, alcohol use disorders and drug use disorders. So those are substance abuse disorders, and then what are known as severe mental disorders. So things like bipolar disorder and schizophrenia. And so we're not going to look at eating disorders that didn't form part of what we were looking at. Peter, yes. So we look at effects. So if we do code effects separately by men and women, but we largely will look at the average effect across them. Many of the studies actually look at one or another gender, but I haven't got that in this talk. We are able to look at whether effects differ for men and women. So, and then the other background, if you're straight down the line, economist, is just that there's some fairly strong evidence that treating mental health disorders is cheap and highly effective. So there's and then also evidence that if you see clinical improvements in these disorders, that's likely also to lead to improved functioning in daily life. And so it's not a stretch to think that if you're getting a treatment that improves your cognition, your sleep, your sort of the stability of your emotions, your social functioning, or your social networks, that's very likely to lead to some economic benefits. And we have evidence that getting one of these treatments does many of those things. So, that just tells a little bit about the pathways through which we might see these effects. And there's also very strong evidence base that both therapies and drugs from high-income countries tend to work very well when you move them across to low and middle income countries. So this review was sort of in the context of we have some sense that these treatments are effective in the contexts that we're working in. And we have a fairly strong hypothesis that if the treatments are effective, we might see effects on economic outcomes. But of course, we needed to aggregate across the data to see if that was actually true. So the search strategy, we pre-registered the search, so the terms that we use, the databases that we use, and so on, so that that was transparent and can be checked. We looked across a broad range of databases. So the first is that we looked across both medical and economic databases. The second is that we looked across databases that would have included working papers, because economics tends to cover a lot, to have a large grey literature. We also looked at 8 trial registries, and if there was a trial in progress, we contacted the authors to check whether they had preliminary results that they were able to share. For working papers that match the search criteria, we also did a hand search of their citation lists to see if we could find new working papers in the discipline. So we were trying to really be as comprehensive as we could to cover across disciplines, and then also make sure that we were covering the grey literature. And then finally, if we looked across languages, provided there was an abstract in English, and then if we did find 3 studies in Chinese, then those were translated over so that we could look at the results. The search strategy, so as we're looking in, so the study had to be in a low and middle income country. People had to screen positive for a mental illness. on a sort of clinical diagnosis. It didn't have to be done by a clinician, but they did need to screen positive on a test. That's important because you will think of some studies in the economic literature that aren't in here, and that's because they didn't do that screening. So CBT has been, or sort of proxies of various kinds of therapies have been used as broad sort of life skills interventions, not with populations who have a clinical disorder, but with the general population. And those wouldn't form part of the search because they're not treating people who've been diagnosed with a mental health disorder particularly. And then people had to be over 14 because we wanted an economically active population. Here we're going to focus, so we did look across, we weren't sure what we would find, so we looked across a range of experimental strategies, but here we're going to focus just on the randomized control trial papers. A control condition could include receiving only the usual care which is available in the country, which is usually pretty minimal. That ends up being the bulk of the studies in the sample. People could also get a placebo. In some cases, so particularly for severe mental disorders, it's often the control group that's used is, so you would have just receiving a drug as the control, so the standard available drug, and then you get, which is called enhanced usual care, and then you get, on top of that, you could receive a therapy. So there's some control conditions which are actually quite strong, and the difference between the treatment and the control is therefore quite small. So if anything, we're underestimating potentially some of the effects by including studies with those control conditions in the sample, but we still felt it was important to include those estimates. And then, this is covered in the paper, but we pre-specified quite a broad list of various economic outcomes, which is covered in the search. And then we included studies that had at least one of those outcomes. So the review were 2 reviewers who independently screened the abstracts against the inclusion criteria. And then there was a 3rd reviewer who resolved if they disagreed. And then one could assess the inter-rater agreement. And that ends up being very high. So this sort of shows the process that we went through. So we start with so articles both coming from databases and websites and through this hand searching process. And then we go through the screening down to the full text. We take out a number for various reasons, and then we include 30 RCT papers, which end up with 30 interventions for the meta-analysis. So then Mark extracted information into a piloted pre-populated Excel spreadsheet with a whole range of fields, and coded all of the economic, mental health, and functioning outcomes in the paper. Just to say what functioning is, because it wasn't a term I knew. So it's broadly the extent to which you're able to fulfill your normal social, economic, and kind of family role. So one example of a scale that measured functioning is the scale of disability. So they ask you, how able are you to perform your normal role at work? And if you have a moderate work disability, you have declining work performance, frequent absence, and you're not very concerned about this. So that's the sort of a scale that would measure your functioning. We also code a range of study characteristics as controls. Tundi then checked this information against the papers, and then we requested information to compute effect sizes if needed. So this is the sample that we end up with. So we don't end up with a lot of, so that's 30 interventions overall. We don't end up with a lot of pharmacological only, so drug only interventions. The main categories are either psychosocial interventions, commonly known as therapy, or what we call pharm and psych or combination interventions. So that's where you receive both drugs, so for example, antidepressants, and therapy at the same time. So we group these together. They seem quite diverse, but there's quite a strong clinical body of evidence that for things that we group together, they have a similar magnitude of effect on mental health, particular mental health disorders. So the treatments actually in other studies have been fairly homogeneous in how much they improve health. So this is, pharmacological treatments and psychosocial treatments on their own. As I said, there is quite a bit of evidence that the combined treatments are a bit more effective, and that's also something that we see in our study. And then there's a fair spread over different conditions, so mainly common mental disorders like depression and anxiety, but also some studies on severe mental disorders, substance use disorders, and PTSD. So Victor, this is an important question. Were all of these interventions pure, or were they combined with treatments like vocational or life skills training? So we did also code treatments that had, as you say, an economic and a mental health component. We can say that those have positive effects on economic outcomes. We haven't included them in the main analysis here because it's not completely possible to see if that's because of treating the mental health condition or just because of the economic component. So yeah, we do have those, and they're in the appendix to the paper. This is the geographic distribution. So you'll see many studies coming from India and China, but also a fair spread over the rest of the world. So we end up with these 115 economic effect sizes and 256 mental health disorder or functioning effect sizes. And so if you think of our data set, each unit or row in the data set is the effect size of one intervention on one outcome. So it actually only ends up being one study where there's a couple of interventions, but you can think of a unit or a row as an effect size of an intervention on an outcome. So if they're multi-arm studies, then each intervention has has separate effect sizes. If there are many outcomes in a study, you get separate rows for each effect size. And if there are multiple rounds, then each outcome in each round will give you one effect size. As I said, the effect is relative to a control. We do also check whether the control condition, whether controlling for the control condition affects our estimates, and it doesn't. The main outcome measure is the standardized mean difference. So that's the difference between the treated and the control mean divided by the standard deviation with a small sample correction. So if you don't do the small sample correction, there can be a bias in doing the standardization in small samples. So we do that correction. So this is the set of outcomes that we, Marcus, so that, yeah, I mean, this is a good point. They could be going from urban wage workers to subsistence farmers, and those things can be quite different. So we've tried to capture that to the extent that we can in the outcomes that we focus on. So we didn't have really enough information to speak a lot about the wage or earnings, which is where I think you might be a little bit more worried. I think if you just going through these outcomes, this may be convincing of, that these might be useful to look at across a range of populations. So employment is whether or not you're doing any work. So, that could apply if you were doing a range of different kinds of work. Various measures of the time you're spending in work. So, like hours worked in the last week. These measures of whether so this is a dummy for whether or not you would say you are unable to work. Then days whether you're unable to work, and then these qualitative measures of your functioning at work. So you can see this makes up quite a lot of the observations, and then they're split across these different kinds of employment outcomes. Claire.
Kate, I had a question as well. This is Peter. So this is all market work, is it? So there's no, if you think about women taking care of kids or doing homework, that's not included, is it?
So it would depend. And bear in mind, we didn't construct these questionnaires. So this is what we have. I can give you a range of recommendations for how you should measure things if you're doing a new mental health study to help us in future. So, this is what's measured across the ranges of different studies. For the employment and time in work, those would refer, I think those questions would refer more specifically to market work, but the and unable to work would, but the days unable to work and the functioning at work, those are quite broad in the way that the questions define them. So we do have an appendix to the paper that shows that, but often they'll refer to both your employment or your tasks at home.
Thanks.
Kate, this is Claire. Sorry, I was just going to ask about some of the variables, or rather the work-related outcomes that you've just asked. So thank you for, I just wanted to understand a little bit better the differences. So employment dummy to me sounds like whether they're employed, yes or no. But then, for example, and like, for example, functioning at work, that seems to get, I think, at presenteeism. And then days unable to work, to me, it sounds like absenteeism. I guess the other two, I'm just not quite clear what they mean. Does time and work mean, number of weeks they've been employed or number of days they've been employed? Unable to work, is that sort of like days unable to work as well? I was just wondering if you could clarify some of those a bit.
So unable to work is a dummy for whether or not you would say you're unable to work. So that, that comes from a couple of different scales that ask that as a question. So that you can just think of that as a 0-1 variable. Time and work pulls together a range of different measures that would look at, amount of time worked in X recall period. So like hours in the last week is one measure, or time, weeks worked in the last month was another measure. So then we standardize those to be able to put them together. Importantly, we're going to show you effect sizes broken down by these categories because we recognize that there are differences in measurement and we don't necessarily want to aggregate up across all of them. So we're not saying that they're the same thing. They're different aspects of work-related outcomes.
Okay, thank you for that. Just one small follow-up question to that. You mentioned that these are measured using different tools or different instruments. Does your paper include the name of all those different tools and instruments that were used to measure these concepts?
Yeah, so
okay.
we give the scale and the wording and the, we've also coded, we haven't yet looked at, like, is there a difference if a clinician codes it or you report it yourself? Is there a difference for the measures that mention ill health specifically versus the ones that don't? So we looked very much in detail at how exactly they're measured.
Fantastic, thank you.
So these are then, there's some other economic outcomes. So we don't really have enough of these to draw conclusions. There's also a bit more heterogeneity in the types of questions that are asked, such that we didn't feel as comfortable pooling them. And then you'll see that there's a range of different mental health and functioning outcomes. So some of these are, looking at suicide attempts or risk of suicide, relapse or recovery. So those are sort of dummy variables, or rehospitalization. Then there's are you using substances or not, or sort of the degree to which you're doing that. A range of scales measuring the symptoms of the disorders. And then we also look at these more functioning measures. So the extent to which you would say you have a disability, how you're functioning in social interactions, the strength of social support or the strength of your network, and then some other measures like self-esteem, cognition, or physical health. So in terms of the empirical strategy, so, it's always difficult to decide how much you're going to aggregate, because if you aggregate too much, people say the measures aren't homogeneous, and if you aggregate too little, it's difficult to learn anything. So what we do is sort of give you a range of levels of aggregation, and you can choose the ones that, we make sure to show them at quite a low level, and then you can choose whether you're happy to use the estimate that aggregates a bit more over outcomes that are measured a little bit differently. So we mainly are going to show aggregations over outcomes that are argued to measure the same underlying kind of construct and be affected by a treatment in similar ways. So, for example, we do aggregate measures of time worked that use different recall periods because we're going to standardize them. But we don't aggregate, for example, time worked with days unable to work because, as Claire pointed out, they're measuring different things. So we standardize the outcomes. So we reverse code everything so that good effects are coded in the same direction. We do this estimate of the standardized mean difference. Then we're going to generate a data set of effect sizes at an intervention level. So if a study has many measurements for outcomes in the same group, we don't want to just randomly pick an outcome. So instead, we take all of those measures for outcomes in the intervention, and we average, we're going to average across them and do a correction to account for the fact that they come from the same study. We also we do this so that we don't weight studies that measure more outcomes more when we average across the different studies. And then finally, we're going to do an inverse weighted random effects analysis. And so that's one intuitive way to aggregate many estimates of a similar effect into one effect. So the inverse weighted part is just basically if it's a more precise estimate, it gets more weight. And that makes sense because you don't want to weight a study with n equals 5 the same as a study with n equals 1,000. You get more information from the bigger sample. So you're going to weight studies that have lower variance higher. And there's proof that that gives you the most precise meta estimate. And then the random effects, there's a huge debate in the health literature about whether to do this or fixed effects. Basically, what we're doing here is that we're to some extent allowing for heterogeneity that we can't explain. We're not necessarily saying, as fixed effects do, that we're assuming that all studies measure the same underlying intervention effect. We assume that studies may be measuring underlying effects that differ in different contexts. And so very broadly, this compared to fixed effect is probably a bit more of a conservative estimate. So this gives you a sense of what the raw data looks like. This is a bunch of different effects on being unable to work that come from different interventions. So sometimes there's two effects coming from the same study, and those would get aggregated up from the same intervention. Those would get aggregated up to the intervention level. So you can see and then you see that these are all mostly using one measure. But then this HUDAS measure, but then there's one in the middle that uses a slightly different, or there are a couple in the middle that use a slightly different measure. So that's the sort of what's kind of under the hood is these different intervention outcome level effect sizes. And then we're going to average up at these two levels across those. So this is looking across the different work-related outcomes. So on average, as I said, we see this 0.16 standard deviation effect. So this is the aggregate Hedges G. This is basically just the standardized mean difference with that small correction for small samples that I spoke about. So you see here, we report the average estimate, the confidence intervals, the number of effect size estimates that this comes from, and then the number of interventions that it comes from. In my mind, when I read these tables, if there's not a lot of interventions, I would probably slightly downweight how heavily I think about that estimate, because it's average. I've just got fewer points of information to draw that conclusion. But that rule of thumb is not accounting for the fact that even if there are few interventions, they can be very precisely estimated, and maybe I should be weighting them up in my own mind a little bit more. But that just gives you a kind of useful rule of thumb to read through the tables. So we see here, we don't have, if we're looking at the different kinds of outcomes, and then the ones with a little 1 next to them are recoded. So the original outcome was being unable to work, but it's recoded so that basically if you're more able to work, so we see an increase in being more able to work, is how that outcome is coded. So these end up being remarkably similar to estimates from meta-analyses in developed countries. So we don't see an overall effect on whether people are in employment, but we do see effects on the amount measures of the time that they have in work, a dummy for whether or not they report being unable to work. So they may not, be they may be able to work but not in employment. But this is just a measure of, you can think of it almost as labor force participation. Would they be able to work if a job were offered to them? We then have also a smaller, but still an effect on the extent to which people, the number of days in the last period that people are unable to work, and then also this fairly large effect on different self-reported measures of people's functioning at work. So that's just to show you kind of under the hood, there's quite a lot of homogeneity. This is only 3 different interventions, but across, we're just not seeing a lot on employment. But then on the other hand, these are the ability to work scales, and we see there's a fair amount of homogeneity, so a lot of overlap in the confidence intervals, which is kind of what you don't want study. Huge amounts of heterogeneity that might make you worry that you're not aggregating outcomes that measure the same thing. We see fairly homogeneous effect size estimates, and then sort of tending towards the positive on people's reports of whether they're able to work. So, Victor, this question of do they report productivity measures, not in the sense you're probably thinking of like hourly wage or manager rating or that sort of thing. So no, we don't have things like that. We do have this mix. So actually, the slide that I'm showing here of either a clinician's rating or your own rating of the extent to which you're able to function in employment. And that can include, so that can be an average rating across, how much are you concentrating, like how much time are you spending on task, are you doing this role as you would ordinarily expect to? There's a bit of a range in the measurement. But yeah, I think you could think of these sorts of scales as capturing a latent productivity, if you like. So this is, not all of these people are employed. Some of them are in housework or in education, or they're not working, but it's their assessment of how productive they would be if they were working. So that's sort of what we've got. So not in a traditional labor economist sense, but it does give you something like that. And then this is just to show that the effects are fairly qualitatively similar to estimates in high income countries, which we didn't necessarily have that as a prior, but I think was quite reassuring that the effect sizes were actually fairly similar. So on labor supply, we see a similar sort of size of effect. Effects in high income countries on sick days are a little bigger than the ones we have in the sample, but not orders of magnitude different. And then the functioning at work measures of the meta-analyses we found were pretty similar. So I'm just going to, sorry, thank you for all of the questions. So we don't really draw conclusions across these other economic outcomes because we don't have a lot of them. So here, this is just showing the result I alluded to earlier. So we see fairly, we see positive, although not significant effects for these single types of interventions. So the pharmacological or psychosocial on their own, but the interventions that are significantly more effective in terms of effects on economic outcomes are the combination interventions. And we see fairly homogeneous effects across treating different kinds of disorders, with the exception of PTSD, but that may be because the PTSD treatments we have, or the PTSD intervention we have, is not particularly effective at treating PTSD. So it may then not have effects on economic outcomes. So I think, Julia, I think I'll probably take, is it okay if I take about 10 minutes more?
Yeah, yes, no problem.
Yeah. Okay. So this is the first of, so we have 2 sets of robustness. So first, just examining or accounting for some heterogeneity in study characteristics. So the amazing team coded with great dedication a huge range of different intervention and study characteristics. So you can see those down the side of the table there. So those include things like whether, evaluation characteristics, so some controls for the type of measurement that was done, the sort of specification. There are also things like the category of intervention that it was. So that's, whether it was psychological only, pharmacological only, or combined. The control condition, which condition was being targeted. Then the things Mark was alluding to in the chat. So, age of sample, gender of sample, any information we had about who people were. Also the implementer, so was it done by a research organization or implemented in the public sector? So we add those different controls successively, and this is just looking at the average effect of a treatment on work-related outcomes. And we see that average effect is still positive and significant, whichever of these controls you're adding in a meta-regression. So that's, instead of saying we don't really understand where this heterogeneity is coming from, we're going to allow it, but we don't really understand where it's coming from. So that was in the first set of estimates that we did. Now we're explicitly controlling for as much very, very awful aspects that would be associated with some heterogeneity in study effects. We try and account for as many of those characteristics as possible. And we see that when you're explicitly controlling for these characteristics that might result in heterogeneity, we still see the effect being fairly robust on the work-related outcomes, which is the bulk of outcomes that we look at. We also successively exclude the 3 largest studies, and we look at the subsamples with different control conditions, and we find the estimates are broadly robust to doing all of those checks for whether study differences are driving the effects, or it's actually the effect is still there. This is also a bit, so this is a sort of more recent part of the paper. So here we're looking at whether there is in fact any publication bias. So this is a histogram of standardized effect sizes. If there were a load of publication bias, so just at that little line just before 2, which is it equals 1.96, you would see a big discrete jump in this histogram of standardized effect sizes. We don't really see that, but there is a little bit of bunching. So visually there might be some publication bias. And so we've been implementing this one check for publication bias. We will also do some others following Andrews and Casey. And the broad takeaway from this, we can go into it more in the question time if you would like to, is that we don't find strong evidence of publication bias. So if you do see publication bias, what you would end up seeing is that studies that had much higher variance, so those are the sort of ones towards the left of the table, in this MLE estimation, those would be much less likely to be published than studies which have a lower variance. So there's a sort of underlying model here. So we're assuming that we are able to model the distributions of treatment effects. We also make the assumption that all effects with very low variance, so very high Z-score, are published. And then once we make those assumptions, we then take the treatment effects in our sample. We make an assumption about the distribution of the treatment effects, and then we make this assumption about the publication of low variance studies, and then we estimate the probability that these higher variance effects would be published, and we don't actually see a very big difference in the probability that those would be published. And so it is possible to do a correction for publication bias using this method, but because we see very minimal evidence of publication bias, so there's not a lot of difference in our estimated probability that the study would be published. If you add, so you can see there, this is what would happen if we did it. The original estimates are the first line, and then the adjusted estimates are the second, and those overlap almost entirely throughout the distribution of Z-scores. So we really wouldn't end up making a lot of adjustments, even if we were doing correction for publication bias. So then finally, just to talk a bit about mechanisms. So it's of a lot of interest to economists to try and understand what mechanisms account for the economic effects of these treatments. So, you know, in a lot of the economic studies that have been done, there's huge banks of outcome measures looking at everything from beliefs to preferences to you know, a whole range of possible psychological mechanisms that might change with the mental health treatment. Obviously, we're not doing our own measurement here, so we can't do everything, but we can look at what studies have measured. And so we have sort of three steps in the argument here. Or three sort of things that we're able to say illustratively. The first is that mental health treatments, there's evidence they affect both mental health symptoms and people's functioning. And that might be important in understanding how they might work in the general population as well as people with these disorders. So mental health symptoms you can think of as, you know, so like the PHQ-9 measures the extent to which you're depressed. And that's what you initially think would be affected by a mental health treatment. So how often have you been bothered by the following over the last 2 weeks? Little interest in doing things, feeling down, poor appetite, feeling bad about yourself, and so on. So those are mental health symptoms. We find that those are affected by treatment. But we also find that these measures, that various measures of functioning are affected by treatment. So, you know, there's improvements in whether people face difficulties in doing their usual usual activities or in social interactions. And so it's quite important to understand that many of the treatments that have worked in low-income settings, like behavioral activation, are ones that actually target people's functioning rather than necessarily targeting their mental health symptoms. So it seems to be possible to achieve these economic outcomes. You know, we have evidence that the mental health symptoms change, but it also just seems to be important to get people back doing their usual activities and back in social interactions. And that lines up with what the mental health world is learning, that you know, while it may be important to try and address these underlying symptoms, you do get some benefit, and in this case, economic benefit in people's lives, just by improving the extent to which they're able to get up and function again. And so the therapy that I spoke about really just focuses on, you know, getting people back to doing scheduling and then doing their regular activities. And that seems to, here we see have strong economic benefits. So we see that there are these two pathways, both mental health symptoms and functioning. We then secondly see that interventions that have larger effects on these mechanisms also have larger effects on economic outcomes. So that doesn't say that, you know, it's very difficult for us to show, or for anybody to show, that an effect of a treatment on an economic outcome works through a mechanism. But this pattern of evidence would be consistent with the treatment, the effects of the treatment going through these mechanisms to have effects on economic outcomes. And then finally, we're going to do a sort of similar analysis in individual level data, just to give you a sense of the magnitude of the association. So this is, you know, in some sense you would expect this slide, but it was reassuring to us that, you know, we know in general that these treatments are effective at reducing mental health symptoms. We also see that in our sample in particular. So these various measures, most of the treatments have fairly strong effects on reducing these various symptoms. But then this was the slide I was talking about that may suggest some of the pathways through which the mental health treatment affects economic outcomes. So you see here that people are quite strongly, you know, less likely to say that they face a disability. They also rate that they're functioning in social interactions and the extent to which they get social support or have a strong network. Those have improved. And, you know, that makes quite a lot of sense. You can think about why that might lead to knock-on effects on work-related outcomes. So this is just showing, it's very similar for the mental health effect sizes, but here we just look at, is there a correlation between work-related effect sizes of a study and the effects on disability and functioning? And we do see, in fact, that there is that a fairly strong correlation. So that the studies which have bigger effects on disability and functioning also have bigger effects on work-related outcomes. So that it doesn't say that that's the mechanism, but it's consistent with that being a mechanism. And then finally, at the individual level, we wanted to try and put a little bit of a, so the mental health treatment may be doing a range of different things, but we wanted to try and give an estimate about, if you were changing depression by X amount, what's the size of the change in days work that you might be able to expect? So one way of doing this was trying to go down to the individual level and look for individual data for some of these studies. So we focus on studies of psychosocial interventions targeting depression and that measured just days able to work, so a subset of the outcomes. And we were able to find available individual data for 4 of these studies. So this is just a subset of the interventions. So we pull the observations together, include study effects, and then we cluster at the study level. And then this is, as you would think in a standard individual level data set, we instrument for the depression score at endline with being assigned to treatment. So, why would you do this? Well, you're interested in this relationship between depression and days worked, but that's obviously going to be endogenous. There might be other characteristics that are correlated with depression that are also associated with days worked. So if the treatment's randomly assigned, we use that as an instrument. And so what the two-stage least squares is doing is replaces the endogenous variable, so depression, with predicted values of that endogenous variable regressed on treatment. So you can think of this as the change in days unable to work that's associated with the change in depression that's associated with getting the treatment. So, it's not just your depression going up and down, it's the change in depression induced particularly by getting this randomly assigned treatment. And so that just lets us look at, give a bit of a magnitude. So a 1 standard deviation decrease in depression associated with treatment is associated with a 10 or 11 day decrease in days unable to work. So that's obviously huge in a month, but a treatment is not going to reduce depression by that amount. It tends to reduce depression by about 0.2 standard deviations. So, using this back of the envelope calculation, if you had the average decrease in depression you usually get from being treated, it's about a 2 to 3 day decrease in the days unable to work in a month. So that exercise just gives you that magnitude. So just to wrap up, so we ran a systematic search. This is studies in low and middle income countries that screen for a mental health condition, test a mental health intervention, and measure an economic outcome. We see positive and significant effects of these treatments on work-related outcomes, measured in most of the 30 interventions that we aggregate, and that's of about 0.16 standard deviations. We don't draw conclusions for other economic outcomes because of heterogeneity. We see similar effects by disorder, so common mental disorders, substance abuse disorders, and severe mental disorders, but not for PTSD. As in the mental health literature, we see similar effects for drugs and therapy, but significantly larger effects on economic outcomes from combining those. And we find then that these results are largely robust to controlling for study characteristics and for tests for publication bias. And then, as I said, we are able to show to some extent that these changes in in work-related outcomes go through changes in both mental health symptoms and in reductions of disability and improvements in social functioning, suggesting that both of those outcomes are going to be important targets for clinical intervention. Thank you. So I think now we haven't got anything. So I'll first have a look and see if there's stuff outstanding. Was there anything, Mark, in the chat that we didn't cover?
I think everything has been answered. Kate has been terrific. Thank you so much. Thank you, Mark, also for addressing all the questions in the chat box. it's a fantastic amount of work. I'm just also curious, how long did it take to go through all of the screening process?
Mark, do you want to make a cast in, or you don't want to think about it?
Yeah, I don't want to think about it exactly. No, I can't remember actually. It took several months at least, but I don't want to make a guess now.
No, but it's very much needed amount of work. So that's fantastic. I think there are some question, or maybe more like comments. Oh, there is a question from Anusha about weaknesses in your study.
I'm not sure if
do you think there were any weaknesses in your study? Anusha is asking. Like limitations, what kind of limitation?
So, I mean, I think the most obvious one is that you're aggregating across disciplines, and so you're not following the measurement standards of we're trying to speak to a labor question without what I would think of as the standard labor measures. So we did make recommendations for a lot of there could be a standard toolkit that it would be wonderful if that could be used in health studies going forward, because I think that many of the things are not the ways we would conventionally measure labor supply or productivity, and that was a lot of where the questions are coming from. So obviously you're bounded by like what studies have done, and I think that's probably the biggest thing. I think the other, interested also what other people think. You are relying on doing aggregation across different disorders, and that to some extent limits the extent to which we can talk about mechanisms, because some of the when we talk about mental health symptoms, that's covers quite a broad range of things. That's obviously in the nature of any sort of study of this kind. But I think it would have been wonderful to have enough studies just from depression and anxiety to have a big enough sample. So I think that would be that would probably be another one. No, Mark or others, any other thoughts on weaknesses?
Sorry, I was busy responding in the chat. I didn't have time to think about weaknesses. Yeah, but I think the ones you listed are adequate. Yeah, for sure.
I have a question, Kate and Mark. I was wondering whether, because we are trying to estimate, to quantify in money terms the employment and the productivity. So exactly, if you receive a mental health treatment and your mental health does improve and you go back to work, in money terms, is your income increasing? Are you so have you seen any studies that actually quantifies in money terms these economic outputs?
Yeah, so the estimate I had right at the beginning. So these here, sorry, the cost estimate. So I think it's the this paper, the Blue Medal, was the last one I've seen of that. So they do try, so they get cost estimates from a range of different countries, like micro level ones that are done, and then so they have like one from Kenya and one from the US, and then they apply those to countries of that same kind. So that's how they get to that that estimate. So that's, and yeah, so that's the one that I can think of doing that. And the difficult thing, I think, is some of these outcomes are much more difficult to cost them. So, if you were able to, if the main place we'd seen effects was on earnings, it would be much easier to draw effects. But it's we really have these kind of more qualitative measures of from days unable to work, that you can get something. But a lot of the effect is at the intensive margin about how people say they're functioning at work. And we know that that's quite difficult to quantify. Yeah.
Yes, like absenteeism or presenteeism. How do you actually quantify it? This is one of the challenges they're facing, trying to quantify in money terms. What absenteeism, maybe you can make a guess, but presenteeism, so like underperforming basically at work, how does that translate in money terms?
And there's this related literature on return to work in developed countries. So there's a lot of the focus there is trying to get people back into work and off welfare. But some of the worry that people have with interventions there is that they're very targeted on getting people back into work very quickly. But then, if the underlying disorder isn't dealt with, and then either there's this sort of presenteeism, as you said, or then those interventions aren't that effective in the long term, because people then end up having the same problem and dropping out of work again. So I think that literature on return to work seems to suggest that one really should focus on treating the underlying disorder rather than just trying to get people off welfare as quickly as possible.
Maybe before I ask another question, let's see if there is someone from the floor who would like to raise their hand or drop a question in the chat box. Noreen has a question. Noreen, feel free to unmute yourself and ask.
Hi, Kate. That was wow. You've been getting a bunch of that in the chat. So great work to your entire team. This was quite the effort. I was wondering if this may well be out of the scope of the paper, but then you could write another one. Whether you have data on physical health conditions that people might have, because of course that affects people's ability to work. And I'm going to guess this is a yes, because you're going through. Yes, we did
actually. I'm just trying to find it. So this was John's suggestion. Actually, we did code these physical health measures. So I was rushing a little bit here, but we do see quite a strong effect on that, and that would be in line with the medical literature. So that big Laird and Clark study that encouraged them to start doing therapy on the NHS. One of the big arguments was that there's a lot of comorbidity between mental health conditions and physical health conditions. And so one of the cost benefits is for the health system, in that you get this improvement in physical health when the mental health disorder is treated.
Yes, and absolutely. And I was wondering, kind of from the opposite end, how we might, not opposite, the reverse, how we could think about that. Because when you have a serious physical health condition, that can lead to depression, anxiety, and other disorders. I'm just wondering kind of how to think about this within this study.
Yes, I think we can't really speak to that. So these are populations in RCTs, so you would imagine the physical health conditions would be randomly distributed across the treatment and control to begin with. So I don't think that the treatment effects wouldn't be driven by whether or not the treated or control had the physical health condition. So I think all we can say is that there seems to be the treatment affects both these physical health outcomes and the mental health conditions, and there would have been a mix of people with physical health conditions and not in the sample. I don't think they do often tell you about did people have more or less severe mental health condition, but I don't think there was a lot looking at heterogeneity by the physical health condition. So I don't know if we can speak a lot to that, but obviously the relationship is super important.
Yeah, I mean, like chronic disabilities or health conditions would be interesting, but this is a great addition to your paper. That's really interesting. Thanks.
As a public health student, how do you think we can combine two disciplines to work on this issue in LMICs? I mean, I think this whole consortium of people have been really excited by how much potential there is just, if you have a fruitful interaction, taking things that are known in one discipline and measuring them to the standards of the other discipline to concretely show the conclusion to the standards of that discipline. So like, when you say to clinicians, oh, do you think that treating depression would affect the extent to which people go to work? They're like, yes, obviously, but there isn't really a huge body of evidence showing that with the sort of measurement of labor market outcomes that economists would traditionally use. And so then, economists are probably less convinced of that relationship than clinicians would be. And so I think just having those discussions across the discipline, saying what are the things that you take for granted, and can we be sure that we have solid proof of them? I think there's an enormous amount of exciting cross-fertilization, because we've also just seen that in policy terms, we speak to very different audiences. So, the clinicians on this paper will talk a lot to the WHO and to people who worry about treatment gaps, but nobody had thought of mental health interventions as a development intervention. And they clearly are. They're having big effects on the extent to which people are able to generate livelihoods. So, I think there's a lot of potential for that sort of just having interactions about what types of things do you think are really, conclusions are really policy relevant, and then demonstrating them to the standards of the other discipline, so that you can speak to policymakers who listen to people from both disciplines. I think there's a lot of very low hanging fruit in that sort of space. I think the other thing is just, for economists methodologically, I think we took the randomized control trial pill very seriously. But I mean, it fascinated me the extent to which we don't see synthesis of studies as being an important part of our toolkit. If you're a health student, as you may know, systematic review is one of the things you do as part of your PhD, is learning to look across and weight different pieces of evidence. And we don't do that in economics at all. And I think, there is starting to be a growing trend to doing it. But I think that the sort of methodological humility and learning from what's been going on in a neighboring discipline is very useful.
Yeah, absolutely, Kate. Leonardo is asking about areas of future research that you find relevant.
So I think in the sort of mental health space in particular, I think one of the things that's really overlaps a lot with the sort of frontier in clinical work as well is trying to understand, what's a sufficient mechanism to achieve the changes in people's life outcomes that you want. So, this point that I was making about, it's actually quite hard to move some of these mental health outcomes with very low cost interventions. So, there's been a lot of work in global mental health on trying to task shift. So get the lowest skilled professional that you can, who's able to administer an effective intervention. But, it's actually turned out to be quite a lot harder to for people with less training to do work that necessarily moves these mental health disorder symptoms. But what we're learning is that if you can get people overcoming their disability and functioning in basic ways again, if you're able to develop fairly simple therapies that do that, that can have this very similar economic effects to treating the more the more complex underlying mental health conditions. And so we don't show that in this study. We only see the treatment and we see effects on both of those types of outcomes. But I think there's a huge amount of really important work in, is it enough if we just get people, treat disability and get people functioning again? Does that have sufficient clinical bite to achieve the change in economic outcomes and to sort of stop the condition from persisting? So I think kind of developing those very stripped down interventions, I think, is really important, because there's been a bit of a backlash from what I hear in the global mental health space that people worry that many of the therapy interventions have been so stripped down that they might be quite a lot less effective. And then you also lose the economic benefits. So I think that, understanding what is just enough is really important. And then also probably, we don't have a lot of evidence. We saw this quite a bit in this study on the long-term effects of these sorts of interventions and the differences across types of treatments. Because I think there've been the one paper we found is a 7-year follow-up, but there are very few like that. And that finds a lot of fairly persistent effects from a therapy treatment. Obviously, it's very hard in a developing country setting to keep someone on drug therapy for 7 years. So, then there starts to be differences between the therapies. So I think the pathways and then also the sort of long-term effects.
Thank you, Kate. Elaine has a question about the type of providers that produce this treatment. Are they physicians, social workers, psychologists? So who are the providers?
Yeah, so there's a mix of studies that are done by research organizations and ones that are done just in a normal, like, clinical government setting. I don't know if we've looked at this in aggregate, but from what I know of the studies, almost all of them are, it's not any of those, it's kind of community health level, a community health worker level, sort of people doing the therapists, because there's I don't think there are any countries in this context who would be able to afford, people with a professional qualification doing the individual level therapy. Yeah, so I'm not sure if we've looked at that, but I think most of that literature is focused on this sort of task shifting to community health worker type people doing the therapies.
Maybe to follow up on Elaine's question, I might ask then who are the users? Are they the general population diagnosed with mental health disorders, or have you encountered also disadvantaged or vulnerable group like refugees or sex workers?
So in this sample, we focus only on people who've been diagnosed with a mental health disorder. They don't have to be diagnosed by a doctor. Like, often the screening is done using a depression scale or a sort of set of symptoms. So it can be done by a community health worker or a nurse, or so. But people in the sample would have had a diagnosis of that condition. I think we did code, Mark, we coded some of the measures of vulnerability, but I think mostly these were general population. There was one with ex-combatants, but it wasn't sort of refugees, or was mostly in a standard kind of community healthcare setting.
Yeah, I could add to that by saying, so we've coded up a more encompassing measure of, I think, disadvantaged, minority, vulnerable populations, some other aspects that went into it. And I think that 5 out of the 30 interventions in our sample, in some sense, have a target like that. So the majority of interventions don't.
Okay, thank you, Mark. While we wait, if there is any other question, maybe Chanel can confirm the recording of the seminar will be on the AIHIA website. And I'm not sure about if the slides will be made available.
Yeah.
On requests, I guess.
Yeah, so if, please contact if you would like to have those. I think I said that yes as the kind of, but the clinicians have different release processes, so we will check with them. But yeah, please get in touch, and I'm sure we can ask them if that's possible.
And I read that the paper is a work in progress.
Yes.
Yeah. Which is your target journal, if you have one in mind?
Oh gosh, we don't know. Any feedback on that would be very helpful. I think there isn't a lot of meta-analysis done in economics. So, anywhere where you found a home for something like this would be very useful. So it's currently written in a more economics paper format. But yeah, so we're any feedback would be very helpful. The clinicians are quite keen to do it in an economics journal because I think they think the message needs to get out. So we're trying for that. Although they think it's very funny how much space we take up in the papers. They're very amused. I think their work tends to be like 5 pages. So they're being very discursive.
Well, let us know once you have a
We will
version
do.
that can be shared, please.
Yeah.
Seems that a lot of people have been asking about that.
Okay, fantastic. We will do. I'm happy to end if there's no further questions.
Yeah, I think that everybody is thanking you for the fantastic work.
Fantastic. Thank you so much for having us.
Thank you very much, Kate.
Thank
you, Mark. And thank you, Chanel, for the IT support. And yeah, thank you everyone for attending. I think we had a peak of 50 plus participants, so it's been very successful. Well done.
Fantastic. Thank you so much for having us and for organizing.
Can I have one last question?
Oh, yes, of course.
Absolutely.
One last question. We talk so much about quality of life, qualis. So was there any outcomes which you have reviewed? Has the quality of life measured? And the other thing is the benefit in terms of actual monetary value of benefits assessed. Those 2 outcomes which I haven't seen in the reviews.
So we did look for the quality of life ones. We didn't find a lot of studies that measured that. It would have been great to have that, the sort of general well-being one. I'm just seeing, I think so we didn't have enough to do a kind of aggregate of it, which was just a function of what was there. I think you make a really important point about, I think we could look at, I think there is other work kind of linking changes in mental health to qualis, and that might be a useful thing to try and do. So sort of getting what's the standard change in disability adjusted life year from getting such an intervention, and might be an interesting way to think about costs. There were some studies that looked at earnings or at the relief in costs that families faced from changes in the cost of the patient having the disorder, but there weren't a lot of those. So I think we did see I'm just remembering, I think it's a small positive effect on income and consumption, but we don't have a lot of studies measuring that. So there's a 0.08 standard deviation, but it's not significant, but that was only measured in 3 interventions. So unfortunately, not a lot of evidence. We would have loved to have had earnings, but there sadly wasn't collected in a lot of studies.
Thank you for that, because probably those are the areas we should take things forward. How many studies were reported from India?
That is it's just below 10. I don't know the exact number.
I am talking from the south of India, from Chennai.
Yeah, fantastic.
I am Dr. John, K.R. John. So I have great interest in this economic interventions. So wanted to be curious about the numbers from India. I think it's 3 to 10. That's what is, I think.
Yeah, it's 9. It's
9.
Yeah.
Okay. Okay. Thank you so much. And can you please put up your email ID so that we can correspond?
Yes, I'm not quite sure how. Oh, I can maybe put it in the chat.
I put it in the chat.
Oh, there. Yeah. There. And you've got marks there as well. Yeah, so any questions or feedback we would greatly welcome.
That's
Fantastic.
super. Thank you very much.
Thank you so much for having us.
Kate and Mark and everyone and Chanel. So yeah, we finished a few minutes earlier.
Fantastic. Take care, everyone.
Sorry, I could not write down the